Hi, good afternoon, everyone.
Hi, sir.
Welcome.
Am I audible?
Yes, yes. You can
Okay.
just try
Check
sharing
the
your.
slides.
Yeah.
Yeah. So did you get the request for sharing? Yeah, I got it. Yeah, I got it. Is that fine, sir? Fine, sir. All right. I think that's good. Good.
I just put a message to other speakers also. Venkat, I think we can start on. Yeah. So I'll
I'm
just,
ready, sir. We can start. I'll whenever you say, I will get going, sir.
yeah. There are a lot of people who have joined. So let us start off with this. So there are a few people joining at this time. I'm just few people joining at this time. I'm just entering them in, and then we'll start.
Sure, sir.
Okay. I think we should start. Good afternoon, everyone. Welcome to the PULM talk number 43 session. And today we have three very interesting topics which will be presented from speakers all around the world. The first one would be from my institute in India, Dr. Venkatadass. He'll be talking about the atypical supracondylar fractures. And then we will have a talk by Dr. Dan, who will be talking about abduction contracture in birth palsy, a much less talked about but a difficult problem to treat. And then we will have a talk on congenital hand conditions treat. And then we will have a talk on congenital hand conditions by Dr. Lam. He'll be talking about the graftless technique for by Dr. Lam. He'll be talking about the graftless technique for the syndactyly release. So let us start with the talk by Dr. Venkatadass. Over to you, Venkat.
Start sharing my screen. Am I audible and is my slide seen?
Yes.
Thank you for inviting me for this series of talks on pediatric upper limb problems. I think I gave one of the earlier talks when the series began about treatment of supracondylar fractures, typical fractures, very long back amidst the COVID pandemic. And when you asked me for the topic, I thought this time I'll talk about atypical supracondylar fractures, tips and tricks for reduction and fixation of atypical supracondylar fractures. So to understand how we are going to manage atypical supracondylar fractures, it is important to know what do we mean exactly by atypical supracondylar fractures. So there is no textbook definition or there is no literature which describes these are all the fractures which are atypical. So what I've done is if you leave out all the typical supracondylar fractures, rest all forms in a group called atypical supracondylar. So what is a typical supracondylar fracture? In my opinion, any straightforward supracondylar fracture which can be reduced and pinned with the two lateral divergent wires, which is considered to be the standard of care, is a typical supracondylar fracture. For example, this one, though the X-ray looks grossly displaced, so this fracture can be stabilized, reduced and stabilized by action and percutaneous pinning in this fashion with two lateral divergent wires, which are rotationally also stable. So this, in my book, is a typical supracondylar fracture. So this, in my book, is a typical supracondylar fracture. So then what do we mean by atypical supracondylar fractures? We have a set of different fractures. The first supracondylar fractures. We have a set of different fractures. The first one is rotationally unstable fractures. So we'll see examples of each of this. This is stable fractures. So we'll see examples of each of this. This will be more like a case-based discussion or a lecture rather than a didactic lecture. Discussion or a lecture rather than a didactic lecture. The second group is a reverse or a medial oblique fracture patterns, which typically needs. Second group is a reverse or a medial oblique fracture patterns, which typically needs a medial pin. You will not be able to stabilize with two lateral wires. The third fracture is fractures with comminution. Not be able to stabilize with two lateral wires. The third fracture is fractures with comminution. Again, you need additional techniques of fixation or associated fractures like intercondylar extension or associated medial epicondyal avulsion fractures. The last part is flexion type supracondylar fractures, which are quite rare, and the pulseless supracondylar fractures. So for this particular talk, I'm not going to talk about the supracondylar fractures with vascular or neurological involvement. Fractures with vascular or neurological involvement. So let us start with the rotationally unstable fracture. So this was like a 12-year-old boy who came with a posterolateral supracondylar fracture type 3. With you can see the hematoma on the anteromedial aspect. So this was reduced, closed, and stabilized with two lateral wires. And this is okay. But when you internally rotate the same limb and take the internal rotation oblique view, we can see that there is opening up anteriorly. So these fractures are rotationally unstable. For reducing these fractures, we have found that a derotation wire in the proximal fragment really comes in handy. This was one of the earlier cases. So we recommend that the wire should be lower down, just above the fracture site is a safer zone. Going higher up can risk the radial nerve injury. So you rotate the fragment and then place the medial wire. Once you place the medial wire, the fracture is really stable. This is the external rotation oblique view, and internal rotation, there is no opening up of the fracture. So this is a typical example of a rotationally unstable supracondylar fracture, which can be used and stabilized with a derotation wire, either in the most often in the proximal fragment, and sometimes you might have to put a wire in the distal fragment also. So you have to understand that every fracture is unique. So the same type of treatment does not suit all fracture patterns. This is the example for a reverse oblique fracture pattern. So you can see that the fracture is going high up medially and then coming down lower down on the lateral side. So this fracture is impossible to stabilize with two lateral wires, and this was fixed with two cross K wires. So this was stable rotationally also after just two cross wires. And this is the 4 weeks postoperative X-ray which went on to heal well. This is yet another medial oblique fracture in a slightly younger child. So the other option to stabilize these fractures, so this was difficult to get even a single lateral wire. You can see that the fracture is exiting distally. So we used the Dorgan's technique of putting lateral wires to stabilize the medial column. So these pins are called as Dorgan's medial column. So these pins are called as Dorgan's pins. You come from the lateral side to stabilize pins. You come from the lateral side to stabilize the medial column. And this is the 3 weeks for the medial column. And this is the 3 weeks follow-up and went on to heal follow-up. And went on to heal well without any varus collapse, and a longer follow-up without any varus collapse, and a longer follow-up of the same patient. So you have to be of the same patient. So you have to be though Dorgan's technique is good for stabilizing the medial column. So you are protecting the medial column. So you are protecting the ulnar nerve. You should understand that it's a trade-off. So if you there are reports of trade-off. So if you there are reports of radial nerve